Welcome to the CME program entitled Laser-Assisted Cataract Surgery, Development and Application. My name is Dr. Jim Sauls. I am a clinical professor of ophthalmology at the University of Southern California and staff physician at Cedars-Sinai Medical Center in Los Angeles. The goal of today's program is to explore emerging laser technology in the field of cataract surgery. Before we begin, let's pause a minute for our first interactive poll question. First, a word about femtosecond laser technology. These ultrafast lasers were first used to perform LASIK flaps over 8 years ago. And so the technique of docking the laser to the cornea to create the flap is familiar to thousands of LASIK surgeons all over the world. These lasers are also now being used for corneal transplants, both lamellar and penetrating, and for limbal relaxing incisions. Why should we think about using these lasers for cataract surgery? There are some challenges with conventional cataract surgery, and maybe one of the first ones is the refractive outcomes. Only 45% of current cataract surgeries result in a result that's within a half a diopter of the intended refraction, and 72% are within 1 diopter, leaving 6% that are actually over 2 diopters from the intended refraction. So these results are nowhere near as satisfactory as the results we're achieving with LASIK. And one of the reasons for this is the effective lens position is often the source of the error, and a half a millimeter difference in the final position of the lens can end up with a 1 diopter error in the refraction. And this is influenced by the size, shape, and positioning of the capsular rhexis, and it's one of the main factors in determining the effective lens position. Posterior capsular opacification is associated with insufficiently sized capsular rhexis, so that's a complication related to the rhexis, and the references are shown on the bottom of the slide. There are other possible complications with current cataract surgery: anterior capsular extensions into the periphery, making the procedure difficult, posterior capsule ruptures, posterior capsule opacification can be as high as 20% within 3 years of surgery. And then there's, of course, endothelial cell loss, which is related to the phacoemulsification part of the procedure. So what are the steps that we are currently using in contemporary cataract surgery, and what are the problems related with those steps? First, the incisions into the eye. If you don't make a perfect clear corneal incision with the proper valve, the incision can leak, and this has been associated with an increased risk of infection. The capsular rhexis is probably the most challenging part of the surgery, and it can be slightly off-center. The size can be either too large or too small, and then a radial extension of the capsular rhexis to the posterior capsule can end up leading to a break in the capsule and complications. The phacoemulsification part of the procedure can lead to corneal edema with endothelial cell loss, breaks in the capsule, and with breaks in the capsule you can have retained nucleus or retained cortex, increasing the risk of retinal detachment and cystoid macular edema. The IOL insertion itself, although the insertion is not that difficult for most surgeons, the capsular rhexis has determined the position of that lens, and so the effective lens position and the centration are impacted by the capsular rhexis. And then limbal relaxing incisions are difficult to get exactly on axis, make exactly the right arc length, and of course have the proper depth without leading to perforation and yet being deep enough to produce an acceptable result. There are currently 3 main U.S.-based companies that are seeking approval for these lasers to be used in cataract surgery. And the current status with the FDA as of this last week is that Alcon, with the LensX system, is approved with their 510K for the rhexis, the incisions, nuclear fragmentation, and the limbo-relaxing incisions. The Lens AR company is currently approved for the capsulorhexis, and Optomedica is awaiting their 5-tunic approval for the capsulorhexis. So what do we need in femtosecond laser-assisted cataract surgery? One of the most important aspects of it is it requires real-time imaging from the cornea to the lens, and this is being performed with either OCT or Scheimpflug imaging. You must then dock the system firmly to the eye while these measurements are being made and the procedure is initiated. And these lasers have to be extremely fast and very accurate in the delivery of the laser energy to make the incisions in the cornea. These incisions include the phaco incision, the side port incisions, and the limbo-relaxing incisions, and then, of course, the fragmentation of the lens nucleus in different patterns. The speed of these lasers is proprietary for some of the companies, but the Optomedica company has told me that they're performing their procedures at somewhere between 20,000 pulses per second and 80,000 pulses per second, which makes these lasers probably very similar to the lasers that we're currently using to create LASIK flaps, the most common use of femtosecond lasers at the present time. As far as the operating room setup, the way this is envisioned is this laser system in most centers will probably be in a separate room, so that if your laser center has 2 or 3 operating rooms, the femtosecond laser would be in one room, allowing preliminary procedures to be done with that before the procedure is finished. So you bring the patient in, dock the laser, determine the size of the rhexis that you want, your configuration of your incision, the type of chopping or softening of the nucleus that you would desire. And this would all be performed in a matter of a few minutes. The patient would then be taken back to the pre-op waiting area and would then wait the opening of a room to go and complete the procedure. So once you've done the femtosecond part, you'll then bring the patient back to a traditional operating room, use standard phaco systems for taking out the nucleus. You'll use your forceps for removing the capsulorhexis, and of course you'll inject the implant in ways that we're all familiar with. So here are the imaging techniques currently being used that image the eye and register the eye. The OCT system is being used by Optomedica and LensX, and the Scheimpflug system is being used by Lens AR. This is a nice image from the Optomedica system showing exactly the view that you'll see in the screen of the laser system. And of course, to perform accurate LRIs and incisions into the cornea, you have to know exactly the thickness of the cornea. And then to be softening and chopping the nucleus, you have to know where is the anterior capsule and where is the posterior capsule, and you have to have enough room to be safely away from the posterior capsule with the chopping procedure or the softening procedure on the lens nucleus. And this shows you the image from the Optomedica system. Here's a nice example from Stephen Slade in Houston, Texas. And this shows you how the laser is docked to the patient's eye. And this is quite similar to what we're all doing with the intralaser femtosecond system. Once the laser is docked in center, the suction is applied, and then the eye is firmly grasped by the docking system. And Dr. Slade is lining it up, getting it centered. And then you're going to see the image that you see on the screen. And this image shows you that he's got on the right-hand side his typical temporal clear corneal incision. On the left lower part, you'll see that he's making a single side port. Your system you might like biaxial or coaxial system, which would use one side port, or you might like a biaxial system where you'll have 2 side port incisions. You also see a diagram of the perfectly centered capsulorhexis and the size of that capsulorhexis. And so all this will be pre-programmed into your laser depending on your particular technique. So here's an example of the LensX system actually making an incision. You'll see the bubbles occurring. This is very much like the dissection of a side pocket incision that you make with the interlace system for release of the gas, only in this case you're probably making about a 2.75 to 3 millimeter incision, and it's cut to the periphery. The next video is from Optimedica, and you'll see the bubbles again occurring in the upper portion of the screen, creating the incision for the entry to the cornea. In this particular case, they were using a typical diamond blade or a metal blade to enter the eye, and in some of the systems I see that they're now using more dull instruments like a cyclodialysis spatula and other things to just finally open the incision. So the incision that is made with the laser is not really an incision until you complete it and open it, just as the LASIK flap. If you make a LASIK flap with the interlays and you just went home, you wouldn't really have any incision. You wouldn't have a flap until you lift it. And the same is true of these incisions into the cornea for the cataract surgery. So here's a side view from courtesy of Dr. Stephen Slade with an OCT image showing you in the upper portion of the screen just how perfect that incision was made. So if your desire is to make an incision that's 2.75 millimeters wide and 2 millimeters long with the bevel into the anterior chamber, that's the configuration of the incision you will get. So we will be able to achieve very precise incisions with this system that will certainly decrease the incidence of wound leaks. And you'll see in the middle of this slide from LensX and Dr. Slade that when he did a study of 45 incisions, he had 100% of them completely self-sealing without stromal hydration, and they were within 1/10 of a millimeter of the intended length. And of course, none of us can accomplish this type of accuracy using manual incisions, whether they're being made with a diamond blade or a metal blade. It would be difficult to duplicate that degree of precision that you can achieve with the femtosecond laser. Here's a very nice study on the capsulotomy. So the capsulorhexis is probably the most critical portion of the procedure, and many of us think that's true. So this is a study by Dr. Zoltan Nagy in Hungary showing that when they did 60 laser capsulorhexis and 60 manual capsulorhexis, they achieved an accuracy of within 1/4 of a millimeter of the diameter that they were seeking. They had no radial tears, and they had perfect centration. We'll show some slides showing the duplication of these results. It's interesting to understand how the laser works. So when you set it up, say, for a 5.5 millimeter capsulorhexis, the eye is then docked to the laser, and the laser actually starts slightly beneath the anterior capsule, and then it cuts forward anteriorly until the capsule is completely excised. So the first few pulses are actually in the anterior cortex. We'll now see an example of that using the LensAR system, where the laser creates the opening tear, and this is Dr. Skip Nickerman in Mexico taking a cyclodialysis spatula, first loosening the anterior capsule, which you can see is cut in an absolute perfect circle, and then he's going in with his capsulorhexis forceps and simply grasping the capsule and sliding it out through the incision. And here's an example of the capsulorhexis after it's been removed, and you can see it's slightly less than 5 millimeters. And here's the second one, performed by Dr. Nickerman the same way, just basically reaching inside the eye, pulling it out, and it's nice to see a perfectly centered and a perfectly round and intact capsulorhexis. This next slide is courtesy of Optimedica, and you'll see a beautiful demonstration of the circular pattern. You can tell that in this particular case, the nucleus has been pre-chopped into multiple little, like, cubes of nucleus, and the surgeon is reaching in and simply pulling out the anterior capsule with the forceps, leaving the pre-chopped nucleus behind. This next slide shows examples of the capsules from the study by Dr. Nagy, which has been presented at the American Academy of Ophthalmology meeting. And on the left, you see the manual capsulorhexis, and you see some of them are torn, and most of them are not perfectly round. And then on the right, you see virtually every one of them is a perfectly round capsulorhexis tear. And then if you compare the results on the slide, you'll see that with the manual system, they were within only 340 microns of the intended diameter, and the standard deviation was 248 microns. And then on the right, with the laser system, they were within 27 plus or minus 25 microns. And then the next thing on that slide, the circularity, is if a perfect circle is 1, the manual results, you ended up with 0.765, whereas with the laser results, you were within 0.94. So obviously a much more sophisticated way of creating a capsulorhexis with much greater accuracy, almost always a perfect circle, and pretty much within a quarter millimeter of the intended size of the rhexis. And that's shown on this next bar graph, where if you look at the laser results on the 60 laser procedures, virtually all of them were within 0.25, whereas with the manual capsulorhexis, only about 10% of them were within an accuracy of 0.25. So it's fairly obvious that we're going to have much better results doing this with the femto-assisted surgery than we can currently achieve with the manual system. This is another part of their study showing you just how perfectly centered this is, and you might wonder, well, why is the centration so important? And centration is obviously very important when we're talking especially about multifocal lenses and toric lenses. Having the lens just exactly centered in the center of the pupil would be the ideal. And this shows you that their deviation from the center was only about 86 microns. So the centration is accomplished by the imaging technique with the OCT or shine plug imaging, which is going to basically center the capsulorhexis exactly over the center of the pupil. Next, let's talk a little bit about the technique of nuclear softening or nuclear segmentation to make the phacoemulsification part of the procedure safer and probably allow us to achieve the emulsification more quickly. So this first video is from the LensX system showing nuclear liquefaction, they're calling it, and you see the laser firing away in these concentric circles. And now that the laser has softened this nucleus, you'll see that the surgeon, in this particular case, this is probably a fairly soft nucleus, so they're doing a little hydrodissection here, and you can see the nucleus moving around. And in this particular case, they go in with just an irrigation aspiration tip, so there's no phaco at all, no ultrasound being delivered, and the surgeon is completely removing this nucleus with simple irrigation and aspiration without ultrasound. So you know you're going to have a very clear cornea on day one and a minimal endothelial cell loss in an example like this. So that's a pretty impressive illustration of the use of the femtosecond laser. The next one will show you a nuclear division or softening in the Optomedica system, which they call the Catalyst system. And you can see the rhexis has already been performed, and now the pattern in this particular case is these little cubes. So you're cutting these little cubes of the laser, which are softening it, and then the surgeon in this particular case will go into the eye and break up the nucleus with sort of a chopping technique. Here they're separating it, but because it's been pre-softened and pre-cut with these little cubes, it's very efficient in terms of the actual ultrasonic phacoemulsification. So this was obviously a more firm nucleus than the one we just saw with the LensX system. So the next slide shows you again what we talked about at the beginning, that in order to do this softening, you have to have very accurate data as to the depth of the nucleus so that you're sure that you're not going to go through the posterior capsule. And so this shows you that you had a safety margin there, that they were never more than 4.3 millimeters from the anterior surface of the rexus, and they had actual about 500 microns of clearance before they reached the posterior capsule. And this shows an Optometrica study basically judging the reduction in the power, and they treated both nuclei that were firm and some up to grades 3 and 4. So about half of them were graded at grade 1 or 2 and half grade 3 or 4. And no matter which, in the grade 1, 2, and 3, there was a 30% reduction in the amount of energy taken in terms of CDE units on the Alcon Infinity system. Was 37% less when the nucleus was grades 1 to 3, and a 40% reduction in the more firm grade 4 nucleus. Let's talk just a little bit about the limbal relaxing incisions. Limbal relaxing incisions are always a challenge because you have to make sure that you have the orientation corrected. The laser you have to pre-mark the eye, and you have to make sure you're getting the right arc length. And this is going to be extremely accurate, we think, using any of these laser systems to perform not only the corneal incision, but the limbal relaxing incisions to reduce the amount of astigmatism. And one interesting aspect of this is not only can you configure the wound in exactly the entry position that you want, you're going to be able to actually perform a limbal relaxing incision without even perforating the epithelium if you choose to do it that way. So it can be a mid-stromal limbal relaxing incision. There are studies underway to find out if those incisions are just as effective as incisions that perforate the epithelium and Bowman's membrane. So we're not sure that they're going to be equally effective, but it'll be interesting to be able to see that we can do them that way. So let's talk now about the next poll question, and let's pause for a minute for our second interactive poll question. So why should we go through all this and expend more money, spend a little more time in order to improve what is already a fairly effective operation? Cataract surgery is certainly among the most effective operations performed on the body right now. So let's compare the effectiveness of cataract surgery with LASIK surgery. So on this next slide, which is based on an analysis of FDA data from the crystal lens for the cataract portion and the wave-light trials for the LASIK portion, the blue is the LASIK and the gold is the cataract. So only 35% of the time in this study did we achieve a visual acuity of 20/25 or better. And in the LASIK, it was 85% 20/20 or better. And virtually 100% of the LASIK eyes had 20/40 or better, as opposed to only 75% of the eyes achieving 20/40 or better with the cataract surgery. And again, the main reason for this variability, we think, is the effective lens position is off. And here's 3 references by Norby, Warren Hill, and Seekick, which show the importance of not only the size of the rexus and the centration of the rexus as a key to having accurate post-op refractions following cataract surgery. What about safety? And here's a slide on the safety comparing the possible common complications of both LASIK and cataract surgery. And cataract surgery is in the gold, and obviously you can have posterior capsular opacification, 10 to 30%. CME has been quoted as 2 to 10%, vitreous loss 1 to 5%, and endothelial cell loss of 4 to 10%. Compared to the common things with LASIK, which usually don't end up causing much trouble, epithelial defects and slip flaps are 1 to 5%. And then vision-threatening complications that can occur with cataract surgery include retinal detachment, CME, malposition implants, the need for corneal transplants, and the most dreaded complication, endophthalmitis, which would be possibly related to the wound architecture, compared to the vision-threatening complications of LASIK, which are only about 0.2%, things like stria, for example. So here's a nice study based on Dr. Stephen Slade's preliminary results using the LensX system compared to manual results. And you can see that in his study, he had a 54% reduction in phaco power when the LensX system was used to pre-soften or pre-chop the nucleus compared to the results of the manual system. And then we've talked about this before as far as the capsulorhexis, but in his hands, only 25% of the time could he perform a manual capsulorhexis, which was in 0.2 millimeters. That's pretty good. I don't think I could get it that close. But he had 100% of these in 46 eyes that were within 0.2 using the LensX system. And then he had found that when he compared the endothelial cell loss, and he's done 200 cases now using this system, the cell loss was significantly less, only about 2.3% or so, using the LensX system compared to about a 6% cell loss, which is comparable to what's been reported in the literature, as you can see by the reference then. So we think that these lasers will be particularly useful in complex cases, traumatic cataracts, cases where you have already a low endothelial cell count, cases where there may be a partially dislocated lens. Cases of pseudoexfoliation will be great to perform these capsulorhexis with the laser. Abnormal capsules, zonular dehiscence, and white cataracts will all be safer with the femtosecond laser system. It's probably going to be contraindicated in some cases. Obviously, you have to have a large enough pupil to have access. Corneal scars could be a problem in having the laser image and get through the scar. Pediatric cases would be difficult, or cases with poor exposure. And there will be some increase in pressure when the laser is docked to the eye. So bad optic nerve cupping, for example, might be a contraindication. So in summary, laser-assisted cataract surgery has advantages and disadvantages. And the advantages, of course, we think will be improved safety and increased precision in terms of the accuracy of the post-op result and enhanced reproducibility. You're going to be able to get more and more eyes to the type of result that you want. And the disadvantage is going to take a little more time, and there's going to obviously be an increased cost both to the patient and the laser center for this laser system.